I'm really encouraged by the previous talks and shows so many successful RCT in the implementation medicine. So my talk is regarding the problem. So this current status of second prevention for patients with ACS, acute coronary syndrome, and diabetes in China. I don't have a complex interesting for this presentation. If you compare the number of coronary artery deaths from 20 years ago to the most update is 2019 by WHO region, then you find the area China located, the Western Pacific region, have the largest rise for the number of people died from CHD. And if you go see the inside the Western Pacific region, used to be 73% deaths from China. So China is the largest contributor for the CHD in 20 years ago, and even bigger now is 81 from China in 2019. And the East Asia area in the Western Pacific, Dr. Zhao is a WHO representative in this region. So China is the largest, the country with the largest number of, so it's really matter because the prevention of CHD and is important for not only China, but for the whole world, especially the region. So when the ACS, the major type of is harmful type for CHD, plus diabetes, there will be have a much higher risk for mortality rate. You can see the one study is emerging risk factor collaboration by disease status, and they use the participant status at baseline. If it's only diabetes as a user, only diabetes as the reference, if you have a AMI, or the risk will increase to almost 4 times. Then if you have it's relative same, if relative same as you have stroke and plus myocardial infarction. So when the AS, acute coronary syndrome plus diabetes, will increase the risk further. So that's why diabetes is an important indicator in all the criteria for the extremely high risk ASCVD patient issued by different organizations. I'm sorry, I didn't translate the word into English because I worked very late to yesterday evening. So all the guidelines from AACE and HACC, the lipid guideline, and also the 2 consensus from China. So then the question is, how many ACS patients with diabetes in China? So what is the magnitude of the problem? Then we published a paper in several years ago regarding the prevalence of diabetes in hospital outcome in diabetes among patients with coronary syndrome in China. And based on a program is collaboration between AHA and China Society of Cardiology. Name is Improve Care for Cardiology Disease in China, Coronary Syndrome Project. And this project is a multi-center registration, include 159 tertiary hospital and 87 secondary hospital. Currently, then we were finished. Now we collect almost 124,000 ACS cases already registered from 2014 to 2020 in nationwide China. Then based on this study, they're showing the prevalence rate is among both men and women is a little more than 1/3, 37.6%, and the women have a higher prevalence rate diabetes compared with men. And this number is almost same in the STEMI, because ACS include the STEMI, the AMI, STEMI, and non-STEMI. The non-STEMI plus the unstable angina become the non-ST, the elevator ACS. The clinical cardiology know that the classification. And except the difference between the men and the women, the people, this you can imagine that it's true that the older people have a higher problems rate compared with the young people. But even in the people, the ACS patient less than the 45, almost 27% have a diabetes. It's very high. It's much higher than compared general population. The people with the previous history of ACS or CHD have higher problems, diabetes compared with the people who don't have. So the really is very high percentage the ACS patient have the combined with diabetes. And the study, our study find that if your ACS plus diabetes, you have a higher mortality during hospital, higher MACE events during hospital, using the we're using the propensity score matched population comparison show the same result. So it's very high. So that's a percentage, but you can imagine that it's over 1 million ACS in China 1 year. It's about the 300 or even the 400,000 with the ACS with the diabetes for each year. So it's a very big number. So what is evidence-based strategy secondary prevention for this patient ACS with the diabetes? So the most recent updating guideline is the just published EIC guideline for the management of cardiovascular disease in patients with diabetes. So compared with it's very detailed, is the central figure for the policy. Most policy is keep the same, and the one new policy is use GLP-1 receptor agonism and or SGLT2 inhibitor as a class 1 recommendation with the A-level evidence. So, and also importantly, all this treatment recommend independently glucose control is regardless the glucose level, and in addition to standard treatment of secondary prevention. So I think that's the most, the first time is with such strong recommendation. And also the less strong, but already recommended by the experts consensus decision pathway in 2020, published on the JACC journal, this American recommendation. And also Chinese expert consensus for clinical management adult type 2 diabetes patient with CVD or renal disease, published in 2020, also recommends use regarding the H1B, A1B, whether or not the level you have to use this two drug, the new type the drug with the evidence show can lower the CVD risk. And also in the just published English version of this year Chinese guideline for lipid management, if you have ACS plus diabetes, then you belong to the extra high risk. It's higher than very high risk, extremely high risk group. So the target for LDL will be lower to the 1.4 more, and 50% reduction from baseline. So it's very low target for the patient. And also for hypertension, if the patient have even is a high normal blood pressure, high normal level blood pressure, if they have diabetes, where is if I can use you have diabetes, the risk is relative with the patient with a blood pressure very high. It's 100, is stage 2. Stage 2 with 1 or 2 risk factors. So those patients have been recommended to use medications. So in summary, so we already know this. There's so many strategies already mentioned by previous speakers. So in summary, reasonable diet, lifestyle, physical activity, no smoking, control obesity and overweight. Then the ideal target is lower now. Most of these patients need starting and plus other lipid lowering drug. And the blood pressure in patient age less than 65, then will be the target will be 130 and 80. Then the ACEI in patient with indicators, beta blocker in patient with indicators. Then GLP-1, RA, and SGLT2 inhibitor is the most updated strategy for the secondary prevention. Then what is the current status of secondary prevention in ACS patient with diabetes? So one study, the study is a clinical trial trying to evaluate, like the previous speaker, effect the mobile text message on the glucose control in patients with coronary heart disease and diabetes. But if you see the baseline comparison between these two groups, is many patients with a higher blood pressure than the target and a higher LDL level, and a higher is a high proportion is like it's almost 40%, 39% in intervention group is smoker and 43% a smoker. So that means for the patient who already have ACS history and plus diabetes, still a very high level of risk factor. And the standard treatment rate is very low. It's war cardioprotection medication, the use rate is only 20% in the intervention group and the control group. That is the baseline information, but showing the situation, secondary prevention in those patients. And also another study is I got only the abstract is abstract in the European Association of Study Diabetes, published in 2020. This study compared treatment status in patient CVD plus diabetes, China and the global level. Then can see the blue one is China for the lipid lowering drug, antiplatelet, GLP-1 RA, SGLP-1 inhibitor is much lower. Then we actually currently is involved with the collaboration study, the No Diabetes by Your Heart, the CDCV project. Is unpublished data is showing that among the AC, I'm sorry, there is a ACS patient with the diabetes. So the primary performance measure for them at discharge include those indicators. Then we find 90%, almost 100% receive dietary instruction before discharge, and a very high percentage patient receive the access instruction before discharge, and record their BMI during hospitalization, and undergoing the glucose measurement, HbA1c, and at least have 2 fasting glucose measurements, and also SGLT2 or GLP-1 at discharge. Then you find that it's still very low percentage people use the newly recommended the treatment stage, and also very few have 2 times measurement before discharge, measure the glucose again. Now we know there's maybe it's infeasible because the currently for the unstable angina, the average hospital stay is just 3 days, so they don't have they just measure at admission, so it's hard for them to measure the glucose level twice in just 3 days. So we may move this indicator later. So, and also among the, it's about 33% of the patient, they have to use these two new treatment, they don't use any kind of SGLT2 and the GLP-1. So that's a situation. And we also analysis all those indicators among those hospitals joining the study. 37 hospitals, there is a big difference in the measurement for HbA1c and for the glucose, fasting glucose, and also the new type, the SGLT2 and the GLP-1. So that's a new measurement with this unpublished data. And also another paper we published several years ago trying to see the patient is a recurring events. So they already have an AMI history, then they have another AMI or ACS again. So they in this study showing only 50, they should under anti-lipid lowering drug everybody, but only 50% is under treatment for lipid lowering, and for among them, about the 40% they say as recurring events have diabetes. Only 53.2% of them use starting treatment before recurring ACS. So I think that's a current status. Is using the available data. So the circulation used to publish editorial. The question is, are we ready for bear the cat? Then when there is some question for cardiologists, why have cardiologists not embrace the therapy that prevent cardiovascular disease? Then the cardiologists contend that it's not their place to be involved in glucose management and fear to advance the events. So in summary, my talk under the topic, the current status for management of ACS plus diabetes. I think in China, more than 1/3 ACS patients have diabetes. Most of these patients have higher risk of death or recurring during hospitalization or after discharge than ACS patients without diabetes. Then the guideline or expert consensus issued by international or domestic professional organization have updated the strategy of secondary prevention for ACS patients with diabetes, recommend for lower LDL-C target and the glucose, two new type, the glucose lowering drug, independent glucose control, because they are both drugs actually take as the strategy to lower cardiovascular risk. So there are considerable gap between evidence-based recommendation and the clinical practice of the management of patient with ACS with diabetes in China. I think it's necessary to further study, identify the main barriers from the aspect of medical provider reimbursement strategy and adherence of patient, and develop effective policy and strategy to promote evidence-based practice for the management of this patient. Thank you very much.